Okay, so welcome everyone. In the theme of, HIV molecular epi, which most of you know I love, more molecular epi is even better. So I am thrilled today to introduce Ann Dennis. She is an infectious disease physician and associate professor at University of North Carolina, Chapel Hill. Her work bridges clinical care, molecular epidemiology, and implementation science to strengthen public health systems and inform timely network-based HIV prevention strategies. She directs multiple NIH-funded studies focused on improving HIV prevention, care engagement, and public health response to emerging transmission patterns. So it's with great pleasure that I turn the floor over to you, Ann.
Thank you. Thanks for the invitation today. I'm excited to be here on Zoom with you all. So today I'm going to talk about harnessing social network strategy, social networks and other next generation strategies. As Susan said, really, I am looking at a lot at molecular epidemiology, but this sort of spans the intersection between some clinical care, public health practice, and some implementation in science. As we discuss HIV transmission and networks, I strive to use non-stigmatizing language and scientific terminology. Words matter, especially when we're talking about communities that are most affected. So I will be using some of these words today. As a brief outline, here's a roadmap for today's talk. So I'm briefly going to review the current US epidemic, discuss some next generation surveillance tools, and then mostly focus on our RESPOND study that I'm running in North Carolina, which is an adaptation of the CDC's social network strategy integrated into partner services. But I'm really going to just focus on that, our formative phase 1 part of that study. But first, let's talk about, kind of navigating kind of shifts in the response. So this, I felt like how maybe last year, maybe end of 2024, how it started. So this, I don't know if folks have been to Jackson Hole. This is Teton Pass, where I grew up, Jackson Hole. Driven this road many times, right? This is steep, familiar, gradient. Last year, this is like what happened, just like collapse from erosion and snow melt. Thankfully, nobody was hurt. But this could, sort of how I felt at the time too, with what's going on in public health. And so in our HIV, response, kind of a fitting metaphor that we've had steady progress, a lot of gains, but sudden disruptions can really change this path dramatically. So we have this, theme, right? Progress mixed with instability, and how can some of our tools, help us respond? So progress is fragile. One of our biggest vulnerabilities to talk about is, of course, is funding. We need stable infrastructure. So, nationally, right, the great progress, new diagnoses have dropped, for instance, about half since 2008. Real progress in prevention and treatment, but kind of stagnant. And the progress hasn't been equal across the country. The South, including the Carolinas, continue to bear a disproportionate burden, across all the kind of stages of the care, continuum. And these data, really underscore the need for, more tailored community engaged strategies, especially in these areas with, slower, progress. And, that brings us to, critical points, without sustained, federal funding, the gains we make can quickly reverse. And here's just a couple examples of some predictive studies. On the left here is showing a simulation study that showed that losing Ryan White fund services could drive nearly 50% increase in new infections. And then other research here published, showing on the right in JAMA that showed that even small cuts in prevention programs like PrEP access could lead to more infections and, of course, higher costs. And so that's why national initiatives like EHE, the ending the HIV epidemic, matter. And, a lot of tools that we use, they have to be, smart, targeted, and, sustainable. So as we all know, I'm talking to a kind of like probably a more HIV focused audience here, who are probably very familiar with, EHE and the goals. We have pretty ambitious goals, and they're going to require, as we get more towards them, earlier and more precise intervention. So the EHE initiative, aims to reduce HIV infections 90% by 2030. And here, pillars, which you're all very familiar with, mainly, focused on kind of the work that I do is mostly focused on that respond pillar. And that's where things like molecular epidemiology and network, analysis, fit in. And then really help us identify, gaps, and tailor interventions to like local contexts, especially in high burden, regions like the South. So where are we at? Now, this is a little bit older data in 2022, but I don't think much better, so in 2022, about 65% of people who, were diagnosed with HIV in the US were virally suppressed. The figures on the left show the prevalence-based, care continuum. And then on the right, among those who are diagnosed, about 76% are receiving care and 65%, virally suppressed. So again, like far below the 95, percent target. So when I talk about, respond, intervention or study, designed to really address, this gap, that motivates our work to, how do I identify networks, especially where we can, close that gap and with retention, places where retention and viral suppression are inconsistent. So HIV transmission, we know it's not evenly distributed, right? It varies by geography, by risk groups, by stage of infection, and the distribution of risk behaviors. That's why really understanding your local context is very important in response. The figure on the right just kind of shows that with uneven patterns and viral suppression by states, with the darker color showing less the proportion of the population estimated to be virally suppressed, right? But you can see like more states in the South, fit into this area. But understanding these uneven patterns is really good for rationale for some of the cluster detection, where we can map where transmission risk concentrates. So, which brings us to the HIV cluster detection and response. It's now a national, program driven by the CDC. Where cluster detection helps to identify outbreaks and intervene early as directed by local health departments. And so this is not just the genetic clusters, but also through surveillance, regular surveillance data, contact tracing, time-space analysis, and in the molecular epidemiology. And so together, these approaches kind of give a multi-layer kind of picture of transmission that just, one of these, cannot fill, like such as traditional, partner services. So I wanted to say a little bit about partner services because, they are, foundational, and the DIS or disease intervention specialists are kind of the boots on the ground to contact and notify people of their diagnosis and investigate and notify partners. Conduct interviews, they do notification, counseling. In North Carolina, it's required by law for HIV and for syphilis for contact tracing and partner notification. And also for HIV, we have programs for re-engagement into care, bridge counseling for those who have fallen out of care. I guess the good news is, right, when partners are reached, by partner services, this is kind of national data kind of highlighted here in this blue box, is pretty high. we're partners to reach about 24%, through, partner services. 24% of partners are found to be HIV positive, new positives, which is a pretty high yield. But as we all know, and, folks that kind of, work in the, public health space, it's for many reasons, people may be unwilling or are unable to disclose partners. But DIS driven partner services capture only a fraction of actual network connections, which is why complementary tools are needed. So this slide here, highlights two complementary approaches to identifying transmission patterns. There's the time-space clusters shown on the left here, and the genetic clusters. So the time-space clusters involves analyzing surveillance data to identify increased diagnoses over a specific, time frame. These are usually coming from the routine surveillance data, also coming from clinics reporting that to the public health departments or community members that can signal localized outbreaks or shifts. And genetic clusters, for those who are not familiar with it, are kind of identified through viral sequence data. And these are largely from sequences that are derived from drug resistance genotypes that are collected in the clinical setting, either during care entry for folks who are newly diagnosed or folks who are experiencing virologic failure. So a clinician will order this to get look for drug resistance, and we'll get a report of the genotypes. However, the labs will retain, that, viral sequence. And with the collection of these viral sequences over on the population setting, you can compare them either using phylogenetics or pairwise genetic distance, methods to identify which ones are closely related to each other. And these sequences that are closely related, short genetic distances, imply some recent transmission links. But when did genetic sequences actually become part of surveillance? So I just include this slide just to remind people that, molecular epi really is not a new thing. It's really evolved from a lot of drug resistance monitoring, and even since in the early 1990s, since we could do sequencing, it has been explored in forensics and other kind of patterns. CDC had a program called VARS, started in 2004, which looked at variants and resistance patterns. But I think that the field really expanded around 2007-ish, when became kind of national guidelines for getting baseline genotypes, because transmitted drug resistance is so high. And so we have lots and lots of genotypes or sequences on a population level. And that tied with just being very, able computational speed, and other programs have improved around that time to allow analysis of these large, data sets. And so which brings us to about, 2018 is when the CDC started was initially a pilot program called molecular HIV surveillance, but that it kind of became required for all jurisdictions that receive CDC funding to report their sequences to their state surveillance, that will then go on to the CDC, and developed a program that they call HIV cluster outbreak detection and response, or CDR. Which is part of that response pillar strategy. So in North Carolina, we've been have a pretty close partnership with our state health department, and so kind of along the way, since I worked in this space, we've partnered with our CFAR and then with our state health department to analyze sequence data. This ultimately resulted in a project called HIV Prompt, which is an NIH-funded study to look at building a statewide surveillance, platform that integrates our local data and helps identify clusters, and also to pilot some enhanced responses to them. And within this, we also have a bioethics supplement. So this is pretty active slide here, and I just get it to just wanted to highlight some ongoing kind of molecular epi, research. HIV prompt study has finished, but we're still, working, continue to work and bring it to other in other directions. We are looking at projects like sequence coverage gaps and also assessing recency of infection. And again, I wanted to highlight the work that we have a bioethics and molecular HIV epidemiology working group, and have put out a number of a couple of recent papers looking at consent, issues surrounding consent, and then working with stakeholders on how to improve community engagement and visibility into this space. But first, I wanted to highlight a little bit more about recency of HIV infection, which I think is like important. And so just to highlight, like, why should we care about acute and early HIV infection? So, we can use our sequencing, identify networks of likely, recent transmission. But the most actionable moment in the transmission is not just like the network, right? It's also the timing. So acute and early infection represent that biologic sort of leading edge of the epidemic. So acute in HIV being importantly, right, detection of these, our sentinel events is really like the leading edge of the epidemic, because this offers an opportunity. These are the true incident cases. So it's an opportunity for rapid ART to reduce viremia and onward transmission, and also to intensify services to identify gaps in prevention and public health. Very analogous to, right, cluster response. That to identify gaps and including case planning and how we can better intensify services to contacts and to the community surrounding folks with recent HIV transmission. So it's just a reminder for some folks that that there's a high rate of transmission during acute HIV. It's defined as that period of time before establishment of an infection. It's very brief, but very efficient. There's very high viremia, right? That very high viremia that can last for weeks before reducing to a set point. And these symptoms can be also very non-specific, right? Somebody comes with a febrile illness and gets dismissed. So the diagnosis is often missed. And then like early infection can also has very, variable sort of definitions that can be usually defined at this period of time, anywhere between like 3 to 12 months following acquisition. Together with, higher viral loads and other factors, kind of shown on the right here, this modeling study, that there's a twofold higher transmission rate during the acute stage compared to the chronic stage. So how do we determine, HIV recency? So this, just this sort of cartoon, just showing kind of various ways. It's going to talk a little bit more about some viral diversity measures, but HIV usually starts out with a single founder virus, and the diversity of the viral population increases usually that first year pretty linearly over that disease course, and so it can be used as a marker to define recent infections. So just like briefly, I wanted to introduce you to primary ID method. This is with the collaborators here at UNC, Shantai Joe and Ron Swanstrom. I won't go into all the details of like primary ID, but on the left, you can see some of the details, some of the advantages of the primary ID kind of barcoding approach. But on the right, I just want to show how we use our deep, sequencing, next generation sequencing, over various regions of the HIV genome. And this model, we use specimens from the CHOPPY cohort, which are folks that had known dates of seroconversion. And we looked at their several samples over time, and had really good correlation between diversity and the days since seroconversion. And so based on this results, we built a recency prediction algorithm, and also field implemented it in North Carolina, looking at new diagnoses from our public health lab. So again, this is work that is being led by Shantai Zhou, but this is our demonstration to our statewide platform using samples that are retained. So folks that are testing positive through our state health lab, which is like a centralized lab. So most like local health departments use it, and they retain positive specimens. So we applied deep sequencing to those samples, and over a 4-year time period, and we found pretty high estimates of recent infection. About 40% of new diagnoses were estimated to be had acquired infection within about the 9 months before diagnosis. And here on the right, you see the graph here that the number of diagnoses in percent vary significantly 2018 to 2021. But as heavily testing was heavily impacted by the COVID epidemic, which is driving some of those changes. So genetic, I want to talk a little bit more about what we can miss by genetic clusters. Kind of going beyond that, right? I mean, we can see very recent transmission, especially if you get like very small genetic thresholds. But you're always at risk of missing other potential members of that transmission chain. So folks that don't have a sequence, they're not diagnosed. And importantly, and of course, this is only looking at folks who are living with HIV, doesn't include those who might have a acquisition risk, and so did not include people without HIV. So identifying these networks really is only by in either way, either from partner services or the contact tracing or genetic networks. Ultimately, it's only kind of half of the equation to getting to that kind of response step, because we actually do need interventions that engage people in these networks. So which brings me to a couple of questions in setting up our response study is how can we improve our responses to incident HIV? And so our rationale here was like there's been pretty limited case finding that happens during partner services, and to like demonstrate this on this schematic on the left, all the larger dots here are individual who is diagnosed during acute HIV infection. There, this is our North Carolina data, and these lines here might be kind of hard to see. They're supposed to be dotted, but it might be hard to see. Are the partners that they named during contact tracing. But as you can see, like there's very few. But when you overlap it with the genetic sequences and the clustering with all these like solid lines, you can see that there's a lot more connections that are drawn. These 4 individuals are all within a much larger transmission network. So this brings us to, how can we engage or do better case finding, especially within recent transmission networks? Can we leverage social networks? Can we use peer relationships to promote HIV testing in these networks, particularly those with incident HIV? Can we better integrate with partner services who are already like the boots on the ground doing the contact tracing? social networking strategies are not routinely used by the health departments. So operationally, they can be quite resource intensive. And how can we learn better? Can we learn more about local transmission using the molecular epidemiology to get some better spatial and temporal insights? And then, of course, with all of this, right, to better engage networks, you need to engage the communities in a meaningful way. So we looked at the CDC's social network strategy as an intervention, to adapt. This is just like a quick overview of what that is. It's an evidence-based intervention to increase HIV testing by leveraging peer influence. And so like the core elements, first in the program is, identifying, a recruiter, a community member that has some knowledge of the social network, that they can exert their influence. But this individual would be coached to engage, how can they talk about HIV testing with their peers, and then they go out and try and recruit their peers, and their kind of model they call the peers network associates, and bring them in for HIV testing. So this is the model that we looked at or the strategy we look at to adapting, to focus on, can we focus this on recent transmission networks, using our surveillance, better understand the recent transmission networks using our molecular data, or these index networks, to guide recruitment. So our study area, this is North and South Carolina, very big states, but our study area is actually the EHE jurisdiction in the Charlotte region. So Charlotte sits right here. You can see my mouse here, but zoomed in, it's Mecklenburg County, which is right on the edge of South Carolina, and it involves some other metropolitan counties. And I also wanted to show, I'd like to show this, just so you can have an understanding of what the epidemic, or what the state kind of looks like. South Carolina is a designated kind of a rural jurisdiction in the EHE, but North Carolina has is built of mainly rural counties, and so it's a very heterogeneous, epidemic. But we selected to actually to adapt and implement an enhanced social network strategy, looking at Mecklenburg County and like the surrounding Charlotte region. And then by understanding and then using molecular epi to better understand how those networks in these counties relate across the two states. Because of course, right, Mecklenburg is right by, right on the border of South Carolina. So our adaptation, just kind of in summary, what we wanted to do in our first stage was to focus on recent HIV transmission networks, to engage people to do the social network strategy. But we wanted input from our priority communities. And the other thing we felt was important was to integrate not just HIV testing, but linkage to PrEP, and linkage or re-engagement to HIV care. And the overall hypothesis of this is that, if we apply the social network strategy towards networks of recent transmission, that will increase uptake in HIV service utilization, compared to standard of care partner services. And so highlighted here's our Raleigh region, that will be like our comparison region. But to give you just another snapshot, since talking about North Carolina, heterogeneous epidemic, underscores the need for targeted approaches. Our state is about 10 million folks. There's about 35,000 folks living with HIV, and there's been pretty stable amount of new diagnoses annually, about 1,400. sorry, my head sort of kind of spins sometimes when I show these implementation science frameworks. I just sort of rely on a lot of other people to teach me some of these. I'm not a card-carrying implementation scientist by any means, but this is our kind of framework when we designed the study. We're using a type 1 hybrid implementation design, so we can evaluate both the effectiveness measures and some implementation measures as we conduct the intervention. We initially designed it to be delivered through partner services and also focusing on these recent transmission networks. And some of the outcomes that we're looking at, like the effectiveness outcomes, are really pretty basic, like uptakes of testing, the number of HIV testing, linkage to care, and PrEP linkages. While simultaneously looking at, there's a lot of implementation outcomes, but the biggest ones, for us initially are, feasibility and acceptability of this strategy. This was our timeline. I'm mainly going to be talking, or I'm just going to be talking about our pre-implementation and our formative, work. But we're in the middle, or on our phase 2 for our implementation side. But the first stage was really integral to develop our adaptation of what we're calling our enhanced social network strategy, or ESNS. So we really wanted to leverage community partnerships and tailor it to community needs. We launched our implementation phase in March of 2025, which is a lot later than we initially had planned. But that's as with any study, I think delays are always expected. But our phase 1 was pretty essential for shaping priorities and how we wanted to adapt. So we're going to focus just on here. This is just a recap, again, of the stages of our implementation stages. Some of the things that we adapted in our program after some of our formative work were some of the terminology and language, not to use like network recruiter and network associates. And so this is kind of the stages with our language shifts. Network recruiters are community ambassadors. And they're coached by through our partner services like DIS, who are part of our study, and UNC employees. They simultaneously conduct partner services and establish rapport with the clients, then to invite them to become community ambassadors. Not only folks newly testing positive, they're not really the optimal folks for to be an ambassador, but it can be anyone within their social or sexual network. And rather than like taking you through all of these steps here, I'm going to try to show you one of our recruitment videos. It's pretty fun. Let's see if this works.
Being a respond ambassador, someone you can trust in our community. No, I'm not a doctor, just a friend who cares. Be ambassador. What is it? To help people access HIV testing, PrEP, and overall care. Whether that's sending a quick link, giving a referral card, or just having a quick little check. Positive or negative, you can be an ambassador. I myself work with a Respond coach, a caring staff member who supports me every step of the way. They check in, answer questions, and help me stay on track. What happens? We meet, we chat, we advocate for my health, and they will advocate for you. And don't worry, everything is completely private and confidential. No one will know who I refer or talk about my health. Yes, no one has access. Being an ambassador is about building trust and making sure everyone feels safe to get the care they need. Together, we can make a difference. Join us, reach out, let's keep our community healthy and strong. And y'all know my favorite part of it. It's a research study. And y'all know I love research. Chat soon.
All right. So I think that's a good kind of snapshot, and how It's really fun, actually, that was developed through a participant in our program. So I'll talk a little bit later about our community advisory group. But we, in our adaptation kind of phase here, formative work, it was informed by our key participant groups, shown here on the left, right? Of course, you have these people in the outer circle and then the inner circle, and then the people that are the folks who receive the intervention are the most important, the priority community members. And looking at evaluating various facilitators across all these levels relate to engagement in these services in the region, and then also looking at the ES&S feasibility and acceptability. So one key finding, and this is stemming from our qualitative work with the public health leaders and the field service workers and social workers, is what we call kind of like the peer paradox. With this is like attention points that we'll have in navigating kind of the implementation, which kind of the information that we kind of learned kind of earlier on, right? That the trust within these networks can either facilitate outreach, but mistrust can easily hinder it. And with these there's three sub themes here that we termed in this paradox. This is led by my co-investigator Megan Zarwell, and also our CPAR team and Carol Golan, who are the qualitative social scientists. But in a nutshell, these three kind of areas with incentives, credibility, and readiness to really give us like a framework of what's going to be tension points to if this can be successful or not. One, like incentives, right? They might not be sufficient to really generate engagement. But you need more than that. Peers might not necessarily be considered to be credible or trustworthy for everything. Maybe they do want to get the information, from healthcare, nurses, physicians. And then, is there the readiness, paradox with people with very, chaotic lives and challenges. Even though the participation on this SNS is a very, short term, it's not a long term. It's usually between 4 to 6 weeks of peer recruitment. But not everybody, might be ready, at that time. And then we gathered a lot of perspectives from potential ES&S or recipients. These would be like potential ambassadors or the potential peers. And here we use mixed methods to get perspectives. And that included personal network surveys. So this is web-based surveys that are about 30 to minutes in length that they take on their own, but use name generators so to elicit the social and sexual networks, better understand these networks, including kind of behaviors within these networks. And then we used several in-depth interviews. We did 17 baseline and then 8 follow-up ones to focus on the initial interviews about barriers and facilitators to care. So the follow-up interviews also to assess more about like the specifics about like ES&S and what it would mean to be an ambassador, and kind of gauge feasibility and acceptability to the intervention. There's some results from that first piece of the formative personal network surveys. So these are egocentric networks. I think just seeing a bunch of networks here is a lot to take in, but just I wanted to highlight this is work that led by a graduate student here. But we had a lot of information. I think this is just the first 51 folks who did the survey. And from these 51 individuals, so these are all like just egocentric. We can't, connect them between. It's just like what they found in their own like personal network. But overall, there were 294 network, members from these individuals, and then describing types of social support, which is shown in blue, and sexual partners in red here, and substance use, sharing partners in yellow. What I think positive things I think we found with a lot of this is a pretty good amount of social support. Of course, we're not showing the different kinds of support and different roles, but we do have that data. But here, just separating out, looking at feasibility within like the sex, are the networks, are there behaviors within the networks? Are we getting into networks that where folks might have recent HIV transmission? And then what does it mean by looking at their network, the network metrics? Some of the larger sexual networks, folks can be more on the periphery. They might have, fewer links between them and the other network members. So that's what we're showing here on the right. And these networks that have more than, one sexual partner, and these are partners within the last 6 months, it's a little bit harder to reach those through, if you were to, they could only be reached really through that initial like index, that person, and not necessarily through their social network, through kind of the data that we get from our personal network survey. So this will like inform like how do you adapt your strategies differently, depending on their kind of social network structure, And then also just like briefly assessing feasibility and acceptability to the ES&S. About 80% of folks, nearly 80% of potential ambassadors said they would encourage most or all of their network to test. But there are also high rates of behaviors facilitating HIV transmission reported. So just another point to feasibility of actually reaching networks of potentially recent transmission. And a lot of positivity during the interviews for the folks that we were very had a lot of effective attitudes towards the program, which was nice to see. So these findings informed our recruitment strategies. These are just a couple examples of recruitment materials. This is a card that can be given electronically or in print from an ambassador to their peers, then to engage with either back to the ambassador or actually they'll go right to our community health coach and our ES&S sort of program to help them link to the services that they need. But very important in this work is our community advisory group, who've been very active and central to the project since we first started through the process. We have quarterly in-person meetings, and actually we developed through participants in the community advisory group, actually ones that that were very motivated to help make recruitment videos, and like the one that I showed you. And we have a couple more that are available on YouTube, which were very fun and seem to get a lot of positive views. So next steps, there's a lot going on here. Not much to mention for time constraints, but we're continuing our implementation. We're finding recruitment strategies. We'll be evaluating our effectiveness outcomes. And I don't have time to really, talk about, how, comparing the intervention to our routine partner services in the standard of care region. Or on the whole, we have a whole aim of looking at spatial extent and features of the HIV networks across the Carolinas. a lot of people to acknowledge this work. These are all like the folks in kind of a response study, but a ton of people too in our prompt study in our lab. This really reflects a big collaboration between our lab scientists, our bioethicists, public health partners, and community members. But I wanted to leave you with a few take-home points for the implications for clinical and public health practice. So, Kirsty, acute infection, right, should trigger some intensified network level response. Molecular epi can guide where enhanced intervention is deployed, but we really need trusted peer networks to extend reach, just beyond kind of named partners. So precision data, right, can tell us where transmission is happening, but we need trusted networks to determine whether we can actually intervene. So that's it. Thank you so much. And yes, I hope this day is not ominous for Friday the 13th, giving a talk on Friday. I'll end that.
Very nice.
How did I do it?
And thanks so much. This was great. And maybe Susan has a question, and Susan, I don't know if you wanted to jump.
I have 6, but I'll just do one.
How about you 2? And
Okay.
then I'll take over with a couple. We'll open it up, but please go ahead.
Thank you, Anne. That was great. I'm just curious, in the intervention phase, the respond, are you going to randomize? How are you going to choose between intervention and control?
Yeah, this is like quasi-experimental design. So it is based on kind of the region. We picked for the intervention region in the Charlotte area, Mecklenburg and the surrounding counties. And our comparison region will be statewide, but then also looking at the Raleigh region and the surrounding counties in the Raleigh area, which have fair similar-ish enough epidemic to compare to.
Okay. And the other question, which I really don't expect, I'm just curious. I ask everybody, what's your answer to this? Acute infection should trigger a rapid response, both network level and individual level. Acute infection is not routinely reported. So A, the delay, and B, the reporting. What's your strategy, or how do we work around that?
Yeah, maybe I'm biased here because North Carolina, we have had but it's been interesting because our approaches have changed, over time. But we were, I think, early adopters, right? To identifying acutes and getting them into care as quick as possible in a partnership with our state. So we initially did, before my time, before I became a fellow. Had,
Chris Pilcher.
Yes, Chris Pilcher, of course. Which is great because it laid a great foundation with our health department, where we have pooling, and in our hospital lab too, we pooled the HIV testing and then tested it for RNA, and we did that at the health department level. But now, right, we're on the 4th generation, testing. Yeah.
And is 4th generation routinely reported to the health department because it's not here?
Yeah, it is.
Okay.
It is. Yeah, so we do get. Even though like our stats, we had a program called STAT, right, for acute. Then have really dedicated people and try to get them into care. We do identify, and especially in our work in Mecklenburg, because I work very closely with our DIS to when we, seeing the whole reporting side, right?
Yeah.
They are so overwhelmed with all the provider calls, right?
Right.
You don't see them as quickly as possible. You really need that person that's doing when you're getting the labs in to know that that you have to get that out as soon as possible. And our DIS and our study are the ones that get those acutes. Yeah.
And I'll just, for everybody who's a clinician on this call or supports a clinician, when you do 4th generation testing and you get antigen positive, antibody negative, that's acute. And reporting it as an acute infection makes a huge difference as opposed to reporting it as a new HIV diagnosis. Okay, I'll get off my soapbox.
Susan, you know that we don't get that differentiation with our 4th-generation tests.
I have no comment.
Unless it's a rapid.
Yeah.
Yeah. If it's rapid, then we can do it. But
yeah.
And I suppose it's something that we can look into, like on the backside. I've never thought about that. Maybe we can talk about that later.
Does it have to do with the FDA approval of the test, like how they report? You know how they're required to report it certain ways? Maybe that's the problem.
Right, but I wonder if you can get the information like on the backside.
At UCSD, at UCSD you cannot. I've tried.
Okay, yeah, then.
But
I just
anyway,
wonder if it's worth discussing again at some point. I don't know.
Probably is.
And there's a question about if you were using any online platforms like Facebook, Instagram, or TikTok. And then I made fun of Facebook, even though I'm on it. The Facebook is for grandparents.
Yeah, we do. We do. I think, yeah, you're right. Like the Facebook is definitely like the older crowd, right? But yeah, Instagram, I've recently, now that we have the videos, right? So we're trying to launch those out there too and putting those on, since they're on YouTube, and putting that through Google.
Cool.
So that's getting some, some traction.
Good.
But yeah, a lot to learn in the social media space.
Yeah. There are probably people here who could advise, but I had one more quick question. I ask everyone this when I see community advisory boards, because it looks like you have a robust and friendly one. Do people get paid or is that voluntary?
Yes, they get paid. Yeah.
Okay.
Yeah.
Wonderful. That's the right answer. It's just
it was a test.
We actually provided, and we designed it to be like in person. In person. We go down to Charlotte. We provide food, and the only tricky thing that we've had is like this venue selection. We've had places where it's just not conducive to be too loud, or the first place we thought, oh, is too clinical. We need to go out to this other place. Yeah, so we're managing that, and but I think getting paid helps.
For sure.
It's about reasonable rates. It's not like coercive.
Right. I don't see any other hands up, which means it can go back to Susan unless someone else wants to jump in. Go ahead, Susan, while people are formulating.
Really don't want to monopolize. So if you have questions, put them in chat or just put your hand up and I'll be quiet. I was just also curious how you're handling what I'm going to call sequence coverage gaps. So what is your coverage, which is the proportion of people who are diagnosed with HIV who have a sequence, which is falling nationally, and generally approximates something in the 50% range, which means when you do network analyses, you miss 50% of the people.
Yeah. Definitely looked at that, and probably I think the last week, it's probably about 70% coverage right now. So pretty good. But I think a lot of our clinics use LabCorp, and that's like the biggest reporter back of the sequence. And maybe there's some other labs that lag, lab companies that lag that we have. But yeah, we looked at that as well to fill in too. The reason why we had our project with the state lab and we integrate those next generation sequences just as a consensus sequence into our cluster analysis.
Yeah. And sorry, just one more adjacent question. I know early on the pooling project was published. Have you done anything more recently to look at the yield of your, contact tracing, partner services programs in the setting of known acute HIV versus not in other states?
Ooh, yeah, compared to other states, no.
Yeah, I mean, you're doing great. It would be great to highlight that, to maybe shine a light on how important it is.
Yeah.
Easier said than done, but hey, yeah.
I know.
Just go out and get a whole bunch of data. We'll talk because we have data from other states.
Sanjay. Great.
Hi, and thank you for the talk. I'm sorry, I'm on a cell phone because the VA decided to cut my internet off today.
Budget cuts.
Hey, I meant to ask, and this is kind of following up to what Susan's question. Do you guys actually get the NGS data from the state lab, or is it still a consensus only?
Yeah, we actually just get the samples from the state lab and we do the
Okay,
sequencing here.
gotcha.
Yeah. And they haven't wanted it reported back to them.
They have not.
Mhm.
Oh,
Yeah, and
okay.
we do integrate it back to our clustering stuff that we do for the state, but
Yeah.
the state themselves they have not
Yeah.
wanted. Yeah,
Okay.
probably too technical and yeah.
And kind of along those lines, the the partner services database. I don't want to misspeak. I could be wrong, but in the recent past, ours is paper. How do
Oh
you
wow.
get the data?
Yeah,
How do you get the data in a timely fashion? There's
yeah,
an electronic?
yeah. So yeah, we have, and this is what we did on our prompt study and why it's been a lot of pieces like to build up to this. But they have a national, statewide, their EPI database called NCEDS. And that's where kind of all like the different kind of EPI kind of reporting goes to, not just
Okay.
HIV, but syphilis. And then when the DIS, it's actually electronic packages now that they fill out
Okay.
for when they're doing the initial interviews. And so when we're doing our monthly like extracts, so what we design with our prompt study is every month when we're getting our sequence data. So the complementary data coming from that I think is important for these networks. We get the
Hmm.
contact tracing data as a electronic file.
Yeah.
A lot of data harnessing and
Yeah. Yeah.
in addition to like longitudinal viral loads.
Yeah. And one more question about the social network makeup. Do you look at bacterial STIs? So, social and sexual network contacts, there are
Yeah,
many, but prioritize those with other
yeah,
bacterial STIs.
yeah. It was look, yes, yeah, and we had like through our in that in our prompt study too, we wanted to feed in at least what was reported, like syphilis, like active
Uh-huh.
syphilis. We've actually looked at some of those kind of networks that overlap with syphilis. And then other ones that they've had another reported like gonorrhea,
Yeah.
chlamydia, and to use that in some of our prioritization if there's too many,
Right.
folks that
Right.
we need to prioritize a certain cluster, and we might base on that if there's syphilis and then there's out of care folks. Well, we hope to, so now we're just getting our kind of updating for our response study. Since on respond, we're also looking at not only folks that have sequences, we're interested in the folks without sequences
Hmm.
and kind of their contact, networks. But we've also asked to integrate the other, like MPOX.
Yeah.
MPOX
Oh,
of it. So
cool.
that's
Okay. Excellent.
Did you get through them all, Susan?
I did. I have a couple more, but I can back channel.
We do try to give people a minute to get to their next meeting or to start clinic. So, and thank you so much. This was a wonderful talk. Clearly, lots of people very excited by this, and I think I don't know if the word was magnifies I want. But is very much in line with the work that Susan and Sanjay and others are doing. Sorry not to leave anyone out. So it's always nice to hear what's happening in other states and how that's going. But lots of thanks from our group here. We appreciate you joining us on a Friday morning.
Thanks so much. Yes, I haven't. Yes, I had a chance to collaborate with Sanjay and Joel and Britt on different projects. So just couldn't integrate it all into this talk.
Yeah.
Fantastic to to come talk to such a great group.
Yeah.
Appreciate it. Thanks
Well,
for doing.
thank you very much. Great talk.
Bye, everyone. Have a great long weekend.
Oh, yeah. Thanks.
Bye.